So we've heard from a number of industry leaders today across a variety of topics that impact value-based healthcare, from unique privacy considerations to healthcare fraud and abuse regulation to new types of healthcare transactions. And we'd like to wrap up today's program by taking a look forward at what this is going to look like in the digital age. Because this is our last panel, that means it's your last opportunity to ask questions on the Slido app. So please feel free to do so. It also means that it is your last opportunity to raise your hand for a true or false question. So here is the statement. The Trump administration's estimate of savings from its healthcare deregulatory agenda is about $435 billion over the next decade. Who thinks that that number is true? Their estimate, that is their estimate over the next decade. I'm not asking you to be a predictor of the number. And who believes that it's false? It is true. They believe that their estimate for healthcare deregulatory agenda is $435 billion over the next decade. It's a very big number. All right, with that, I'd like to welcome our panelists. First, we have Cindy Ehnes, Executive Vice President of Consulting at Cope Health Solutions, Brett Friedman, Partner at Ropes & Gray, Steve Phillips, Senior Director, Global Health Policy at Johnson & Johnson, and Betsy Mountenay, Analysis Manager at Bloomberg Law. And Betsy, I will leave it to you to get the conversation started.
Fantastic. Thank you, Susie. So congratulations, everybody, on making it to the final session. We have a really exciting panel for you today to talk about what's next in the digital health age. So Cindy, Brett, Steve, thanks so much for being here. So it's kind of impossible to have a conversation about healthcare without thinking about the new emerging technologies, whether they are going to, improve patient outcomes, save lives, track wellness, provide some sort of assistance to doctors, whatever they may be. They're all coming, but the big question is, who will pay for them? Will they be reimbursable? And so, Cindy, I want to kick it off with you because you have a unique perspective on this. For those of you who don't know, Cindy was the director of the Department of Managed Care for the state of California for 8 years, so she has a unique policy perspective. So what are some examples of new technologies that are emerging that create barriers to payment? And how do you help both patients and providers get both the payment and the new technology? And then what do you do about the subsequent uneven adoption that can happen when there are these barriers to payment?
Okay. Well, I have to go back just a little bit to why I became interested in this area. As the chief regulator for managed healthcare in the state, I became very concerned about what I saw in the adoption of quality scoring between the haves and have-nots in terms of the ability to adopt and use technology for that reporting. And what we saw very quickly was what you call a bimodal skew, where the rich did richer and the poor did poor. And that alarmed me in terms of the quality of healthcare. The second thing I saw as director was how the integrated systems were able to improve their quality scores much more quickly because, like Kaiser, they were able to create those care prompts at the point of patient access. So if you came to a receptionist at Kaiser, she would say, "What, you haven't had your mammogram?" and schedule you right there. That was one of the primary reasons why Kaiser was able to improve their scores. I'm going to move up just a little. So. And then the other thing is just patient records available. I was a cancer patient when I came into my job, and the thing that I was most impressed with was the fact that I was able to have my patient records all available at the point of care for each of the specialists that I was seeing. So I was seeing like maybe 4 or 5 specialists, and each one of them had access to my patient records. And I decided then that that was a right and that the entire system has been much too patient about about the fact that people don't have actionable data at the point of care that allows practitioners to practice to their optimal capabilities. So anyway, I joined Copal Solutions because we're passionate about value-based care and about bringing together all the elements of the system. But the important, a couple of important things. The first is that there's always sometimes a tremendous mismatch between what you see people think is going to be effective and what's actually adopted and used over time. So you first have the issue of, is the device, for example, actually technically a feasible device? Meaning, is it accurate in collecting the information? Take the Apple Watch. They did a study on the Apple Watch and determined in this study that the information was accurate only 67% of the time. Well, I mean, I don't think, you understand that no practitioner is going to base a change in practice, particularly on that kind of a statistic. So that question of, is it in fact fit for use? Is it reliable? And then the second thing is, does the patient who's using perhaps a mobile device use it frequently enough that they in fact produce longevity of data? That's the first barrier, is patient use. Second is clinician adoption. Is this information relevant to the clinician? Is it in an actionable form? When a clinician is getting like 6 different feeds of information in different formats, ultimately it ends up not being very usable. And I had a great example of this because I was writing a regulation on quality, and I went around and talked to providers, and one provider brought it home. He said, every health plan sends me their little book on quality and what I'm supposed to be collecting. And he said, and they send me this manual, and then somebody else sends me a manual, and another one, and another one. And he said, what I do is I put them right on the end of the desk, and I stack them all up, and when they get too high, boom, they just all fall over into the wastebasket. And you know what? That's absolutely true in this arena. It is absolutely true that to the extent that clinicians cannot receive actionable, relevant, clinically relevant information, they do not use it. You can exhort them to, you can beat them, but they can't use it because they are the masters of their profession. I mean, that's what they went to school for. And so then the third component is cost effectiveness. And in this area of digital adoption of digital technology and technology in general, that question of who is it cost effective for is a major barrier to adoption. So if we talk about I'll use an example because this was brought home to me by another hospital, a person in a hospital, the finance person. He said, okay, you want me to move to value-based care. So you want me to move all my care out of the hospital. And so I no longer get paid for the inpatient visit, but I still have all the costs of the inpatient system. And then you moved it to the outpatient system, and there's like a very teeny little reimbursement for that. He said, you tell me how the numbers work. And I would just cite that to you. If you cannot solve that equation, you cannot advance adoption of both digital technology and value-based care. You can't do it. And unless you're really embracing that, which is, again, why I went on the healthcare consulting side instead of the attorney side of my training, it was because answering that conundrum is an accountability, I think, of each of us to really figure out how to do that. And I'll have some remarks later on, but I think I'll leave it there for now.
So Brett, one area where you are particularly advising clients is the direct-to-consumer area and telehealth. Telehealth has obviously a lot of promise for both, improving patient outcomes and also saving money and being more cost-effective. But there's always the challenge of whether it is reimbursable. So how do you see what's reimbursable? How is that evolving under the new payment structures?
Yeah. So telehealth, obviously an evolving, growing area. It's a component of lots of digital health technologies in the value-based payment space. I used to break down telehealth into two big buckets. The first bucket was, I'll call licensure. And that, I would say, the last 5 to 7 years of telehealth advising was almost exclusively focused on licensure, which is, how do I actually deliver telehealth in a 50-state environment? How do my clinicians how do I structure myself? Am I an MSO captive PC? Where do my clinicians need to be licensed? Can we do cross coverage? And trying to really figure out just the delivery mechanism, delivery system, and then the technology, right? FaceTime is so prevalent, and synchronous telehealth technology is so prevalent now and cheaper than they've ever been. But that was like the huge focus, and now finally people are saying, okay, this is great. How do we get paid for it? I'll start with what I'll call the elephant in the room, which is, this is a value-based payment or value-based healthcare conference. And so one thesis of reimbursement is, if we move to a risk-based model and we have an adequate telehealth component, and that telehealth component is cheaper from a cost perspective, and it keeps people out of the doctor's office or out of the emergency room or out of urgent care, then we're saving money on a total cost of care, total spend basis, right? That is, I think, a beautiful theory. Is that theory going to play into fruition? I hope. With the recent change in the Medicare physician fee schedule, which is creating new CPT codes that provide for consultation pre-visit, and because there's a recognition, at least now by CMS, that a pre-visit consult through telehealth, to the extent it avoids a physician office visit, should be reimbursable. I think there is a movement to this sort of cost avoidance reimbursable event episode of telehealth. Again, I think it's theoretical. I tend not to sort of, I want to say hang your hat on like potential future cost savings. And so that brings us to, okay, well, what does the telehealth reimbursement environment really look like? The one thing most of my clients know right off the bat is that Medicare doesn't really reimburse telehealth. There's a long-standing statutory prohibition outside of the rural care environment that telehealth on a Medicare fee-for-service basis is largely non-reimbursable. And so what do we do? On the federal side, there's, I would say minimal expansions and thoughtful expansions to the extent possible. We talked about the sort of new consult codes. There's the demonstration programs through CMMI have done really good jobs, like NextGen. You can apply for the health waiver and get reimbursed. And there's different, the Chronic Care Act provided new additional telehealth. There's Medicare Advantage and treating telehealth as a supplemental benefit. There's definitely movement and momentum on the federal payer side in order to get telehealth reimbursable. The states, too, have been increasingly, I'll call them good labs for innovation in reimbursing telehealth. Medicaid programs have been far ahead because they're not so constrained by federal law in order to provide telehealth coverage for different conditions. But what I'm finding too is that the nature and the nature of the telehealth as it becomes increasingly important. I view telehealth as sort of 3 large buckets. You have your synchronous telehealth, your audio-visual real-time communication. You have your store and forward, which works for ophthalmology, dermatology, radiology. And then you have your remote patient monitoring, which is the Apple Watch example, and the accuracy of that data collection and whether it can result in meaningful clinical action. And so I think on the synchronous telehealth side, you're seeing a lot more reimbursement on telehealth. On the federal side, as we mentioned, definitely on the state side, and then commercial payers. Store and forward, I think increasingly, becoming actionable and reimbursable. And there are new CPT codes that correspond better to store and forward. Although there are limitations to store and forward given historical abuses, like the whole, erectile dysfunction meds in the 1990s, their branching questionnaires. People are still hesitant in limited categories for asynchronous store and forward telehealth. And then I think remote patient monitoring, especially in the cost avoidance realm, is really, I think, the wave of the future, which is if you can incentivize the reimbursement of clinicians to make the investment and educate their patients on remote patient monitoring, especially for chronic conditions like diabetes, and for people to enter the data or for the data to be recorded and then to feed back to the clinician so they can do, again, just remote monitoring on a visit-to-visit basis and making that reimbursable in a way that's going to capture the cost and time investment for both the provider and the patient. I think that's really the future. But what I'm seeing a lot in my own practice is a lot of my digital health clients are saying, we don't want to mess with reimbursement. We just want to go right to the patient, and we want to have the patient buy the drugs they want to buy at a low-cost generic drug price. New York City's rife with these. You kind of see them on the subway ads, but most of them are lifestyle drugs, and through using the telehealth channel as a way to supplant as opposed to supplement the traditional provider-patient relationship as a way to deliver then the treatment that the patient selects. And most of that is not reimbursable. It's paid out of pocket, but it's a way of essentially self-diagnosing and providing the care you need. And I think there's a lot of benefit to that, especially when you're dealing with things that are not necessarily prescription drugs. I think that's the millennial mentality is I want to use the telehealth conduit as a way to get the treatment I want, not to use this as a more convenient aspect of how I'm going to interact with my provider generally. I think we're going to start seeing as consumers take healthcare in their own hands through a telehealth environment, a little bit of regulatory pushback on exactly what the licensing bodies and what the payers think of that. Because in addition to the self-selection, when you do that, to your point about interoperable and available medical records, who's recording that information? And is that going to be available to all of your points of care? Probably not. And so while it provides more convenient access, does it result in overall better value-based care? And I think the jury's out on that. So I'll stop there.
And Steve, in your role at Johnson & Johnson, you're working on some new projects involving technology. You talked about a collaboration with Apple and a new AFib device as well, I believe. What are some of the regulatory issues that you've had to deal with working on these new technologies?
Okay. It's, as I was thinking about, kind of where to start with my comments here, it's a little bit hard because, this conference has done a really good job of pointing out the many issues and, from the panelists in terms of, projects that are happening. And J&J is definitely very much engaged as others are. I guess one place I would start, getting into some of the specifics that you asked about, but as Brett was describing, telehealth policy, that's actually one area that we're not currently involved in, and but I wanted to point that out because it's I think important for people to kind of at least have an understanding of some of the terminology here, because I know I've often heard people talk about telehealth and use that synonymous with digital healthcare, and it's not, because we're very involved with many aspects of digital healthcare. Telehealth, which is at least for Medicare's definition, is providing care remotely at a basically kind of clinical services to a remote site. When some of the areas of digital healthcare where we are involved is we are. You mentioned Apple and the atrial fibrillation app. that is they're developing, and it's been in the news earlier this year that J&J has entered into an agreement with Apple to partner to review the data associated in terms of identifying patients with atrial fibrillation prior to them being symptomatic, which for that clinical area is a very important step because that there is an opportunity at that stage to have an impact on the development of the disease condition. So that is one area, and it is I think a good kind of example of all these issues at play. Will that be reimbursable? I think another aspect that payers consider is, is this being used for people who have atrial fibrillation, or, is it for, anyone who buys the Apple Watch and maybe wants to know if they have atrial fibrillation? And in that case, generally it's considered a screening tool and would not be covered by payers, certainly not by Medicare at this point. And just to illustrate kind of the difference, on the way out here was looking at a proposed Medicare coverage decision for 24-hour blood pressure monitoring at home, and that is something Medicare is proposing to pay for, but it's after a patient has shown signs of having high blood pressure. White coat hypertension, I think, is the condition. They actually cover it at a certain level. They're proposing to lower it. But so, it's really, that's one of the ways to think about this, I guess, is if, if the patient is already symptomatic, then, these have been considered remote monitoring. If it's the general population, even though there's certainly benefit in finding out if you have atrial fibrillation, it's a little bit more of an uphill lift, and right now probably, at least with Medicare, would not get coverage. But where it gets more flexible is as we're talking about value-based healthcare and these different models, that there is more flexibility, certainly with commercial payers and even on the Medicare Advantage side. Another offering that J&J had was digital health coaching, and which was a kind of a personalized online approach to lifestyle behavioral changes targeting certain conditions, and had published results with commercial payers of the benefits of this online digital health coaching. We actually approached Medicare traditional fee-for-service through the Innovation Center, as saying, look, actually Medicare Advantage plans were offering this, but ultimately, we were not able to convince them that this is something that they would benefit from offering to their population, because it's not a physician service, it's not a hospital service. They don't have a benefit category in the law to fit it in. So that is, an example of, a really proven effective program that has, at least for Medicare fee-for-service, run aground of the current regulatory structure. One other example, and then I'll stop, but maybe it's helpful to get some specific cases for people to wrap their heads around. Earlier, in an earlier session, there was discussion about the challenges of bringing innovative technology into the market because of the regulatory framework, specifically FDA. And if an application causes patients or consumers to take action, AFib as an example, that can trigger, where it needs to have FDA review. And what I wanted to mention is actually, that the FDA has recognized this challenge that can present because, whereas they're, have established pathways for regulating medical devices and drugs, software applications are a whole different ballgame. So they've created what they're calling a digital healthcare pre-certification pilot, and FDA, J&J, along with Apple, Fitbit, I don't have the whole list of other companies memorized, but it is a pilot to test this concept of actually approving the organization, pre-certifying the organizations, rather than having to, kind of open up a brand new full review for each piece of software. So it's just getting started, but I think it is a very relevant and exciting development that hopefully will accommodate what needs to happen.
So one of the challenges of all of this new technology, of course, is that it results in a lot of data for providers. And that can be a really good thing, but that can also be a challenge. As Cindy alluded to, like too much data kind of just means, it's not useful, or if providers don't understand how to use it, again, not useful. So I wanted to ask each of you, what does the healthcare industry need to be doing with this data that they're getting from mobile devices, and especially how do they use it effectively in this value-based care system?
Well, first of all, let me start with the premise that I think that the only way that you bring it together into something that ultimately creates anything we'd call systemness is value-based care, period. Absolutely. There is really, in my mind, and I've been in this industry a long time, absolutely no other mechanism that aligns the various interests into something that starts, again, resembling an alternative reimbursement model that incents the things we want to happen, which is, again, I'm very passionate about that. So the question then is, what are the technologies that in fact alter the course of care at the point of care, or in a way that creates a non-visit, I guess you'd call that. And this issue of data overload is such a big piece of so much of the whiz-bang of digital technology. There is simply too much data that gets generated that hasn't really thought through to the end user, and how will that end user use it to modify their practice, or for, in fact, the consumer to modify their lifestyle, which is, of course, as they say, the 50% of all health incidents are a result of lifestyle. So ultimately, consumers now who are paying more for care ultimately have to become better able to rationalize what is the data that they're collecting and producing, and what is the expectation they have on the part of their practitioner to actually do something with that data. There really isn't much discussion of that. And so I think at the end of the day, number one, the process of aligning interests through value-based reimbursement is the process by which you start weeding out a lot of the technologies and the whiz-bang stuff that ultimately isn't going to transform care in a way that is most cost effective. So I would say ultimately, you just have to start using that as the discussion and the mechanism by which we are paying for care.
I mean, I'll start. I mean, I've been doing value-based care now for a number of years, and I've become very cynical over what data can show in terms of doing, whether interventions, whether programs, whether collaborations actually are directly attributable to meaningful cost savings. What I've seen sort of like over the last year to two is that you have a lot of provider collaborations, whether they're ACOs, IPAs, other types of population health initiatives where the buzzword is total cost of care. And we're trying to, whether it's based on a medical loss ratio model or other type of model, we're trying to take and manage the total cost of care for a population, bring it down, and get rewarded on the delta that we create. And the primary challenge and the primary question that these collaboratives are asking at the outset of these initiatives is, do we know what the total cost of care is? And for the most part, the answer is no. If they're Medicare or Medicaid beneficiaries, the providers who are looking to the total cost of care don't have access to the data. It's usually Medicare or Medicaid administrative claims data, which is very hard to access for the population you're intended to serve. And so that's a huge impediment to the data. And then I know we were talking earlier about your experience with DSRIP, which is the New York State Medicaid initiative, and there were huge problems at the inception of DSRIP for the ability of these performing provider systems, which were regional collaboratives of providers who could access the Medicaid claims data necessary to determine whether the projects or interventions that they had to perform were actually effective at doing what they were supposed to do. And I find that a lot of providers or a lot of payers will take credit for the same total cost of care reduction, even though they're doing different things. So how do you actually attribute and show it on the data that this intervention or this program actually yielded the cost savings that I've said I'm going to yield or that I've promised as part of the agreement? And then the second piece there is who controls the data? I think now we're in 2019, we're probably a cycle and a half through the first wave of meaningful value-based payment arrangements between providers and payers in the post-ACA environment. And I'm getting a lot of calls, which is, did we actually do, how much are we supposed to get paid now on these contracts? And it's resulting in disputes, which is to say, like, okay, your data health plan says X, my data says Y, whose data is correct? And the lesson I've learned as a lawyer who negotiates these contracts is always have a really good dispute resolution process in these agreements, because you're going to need it, because it's based on the access to data and whose data is right and what does the data show. This isn't just you submitted a claim at these payment rates and it yields a result. It's it's a mishmash. And so the thing I've been putting into complex, especially downside risk contracts, is what I call the neutral independent actuary provision. And I have a few friends who are actuaries, and they're far more interesting people than you think they would be. And they're I've said, like, are you seeing a lot of these? And they say yes, right? Anytime you're taking meaningful downside risk because of the data disparity and the ability to manipulate data to reach an end result, you want someone who's neutral, independent, and knowledgeable to be able to assess and resolve a dispute short of litigation or arbitration. This access data, what it shows point is really, what I'm correcting for in my contract negotiation now.
Okay, well, I'll try to think maybe farther into the future and end on a more optimistic note. I think you're correctly cynical of where we are. I mean, all of these things take longer than they should, and certainly than you think they're going to. But I would also say that one of the things that I really liked when I heard about this session was the title, the future of value-based healthcare in the digital age, because I think that those two things coming together is what is going to make this work. And I guess what comes to mind is particularly in the area of genomic based medicine and work that's going on now in terms of really disease interception and really identifying based on biomarkers patients that are potential and even imagine as that work progresses with more accuracy in terms of being able to like I said, like the term says, intercept disease. And so that, like I say, I'm definitely looking into the future, but not so much that, I mean, there's a lot of money going into this right now, and then there's actually FDA trials and discussions with some of this work. But the other big piece that is again, there's work going on. The Patient-Centered Outcomes Research Institute is PCORI is really geared around bringing together outcomes research that can influence patient care. And I mean, if you think about how do we move the needle here on value-based healthcare, having at the clinicians fingertips on the tablet and in terms of relevant information is again it's futuristic, but it's direction people are looking at. So I think that's why it's so important to try to resolve a lot of these issues.
May I mention one other thing? One thing you had asked me to talk about is just this issue of how when you perhaps are representing either a provider organization or doctors or even a device company, that question of how do you get adoption for reimbursement purposes at the Department of Managed Healthcare and at the Department of Insurance, there is the mechanism called the independent medical review process. And in California, that's actually very robust in terms of a mechanism by which a lot of new technology gets incorporated into care. And I use the example of digital mammography. And digital mammography was initially something that first of all didn't exist, but then as the technology came in and began to be much more reliable and accurate in terms of predicting, particularly in dense breast tissue, the small tumors, that was subject to hundreds of independent medical review requests, which frankly bothers me as like, really? I mean, the health plans aren't aware of this. Yeah, sorry, that was a little editorial. But that over then time, the number of decisions that started going against the health plans, I think 90% of them were overturned, ultimately results many times in the department or departments issuing a directive that basically said, you know what, this is standard of care now. And that is actually, I think, a mechanism by which new technologies can, in fact, be incorporated into standard of care and standard of practice in California and maybe in other states. I think there are many similar laws. In California, there's also what they call CHBRP, which is a charming name, that does requests for mandated benefit reviews, and they do analyses. It's the California Health Benefit Research Program policies, whatever it is, CHBRP. And so they will produce an analysis for the legislature. So if there's a request for a mandated benefit, then CHBRP does that analysis. That's another way that advocacy groups get mandated benefits through. And then there are also, like Blue Shield, I believe, still has a technology assessment forum. And there are a number of these that, that in fact do that kind of review. Another one that works in the area of total costs of care is Integrated Healthcare Association here in California, IHA. Works on defining total cost of care and reporting analytics around total cost of care. So there are some mechanisms by which you can, in fact, accelerate adoption in reimbursement.
So we'll turn it over now to Susie with questions from the audience.
Thank you, Betsy. So I think that it's the end of the day and our audience might be a little tired, so they didn't have any questions.
Oh, good. Okay.
That means everybody answered all the questions.
Yes,
Yeah,
you guys were very thorough, and
Yeah.
thank you
Predictive analytics.
very much
Yeah.
for
Yeah,
a
our
great
predictive
panel.
analytics were good.
Yeah, exactly.
Yeah, yeah, very good.
Great. Well, thank you very much.
Thank you.